mute until they tell start. Well, then I can't hear.
Okay, is it 10 a.m.?
Yes, ma'am, it's 10 a.m. We'll turn things over to you, Representative England.
Good morning, everyone. I know my colleague, Representative England, is on. We have Representative Boyd. I know Representative Rolanda Hollis, Representative Warren, and there are others that will be joining us. But we are honored that you've chosen to spend this time with us again today. For the past week, we've had looking for answers for all of the questions that we have, and so we are honored to have the panelists that are with us today. I'm going to ask Representative England if he would go ahead and begin this session, and I'll start with the next one. Do we get him? I know he's here.
Yeah, somebody, the host keeps muting me. I guess they don't want me to talk today.
Oh, they can't do that to you. They have to do that to me too.
I know. We're in this together.
Right.
Good morning, and thank you for joining us today. These have been enlightening sessions, but I think today is probably one of the more important ones that we're doing. Not that the other ones weren't, but considering what we're facing and the fact that we're trying to reopen in this pandemic, it's I think that the opinions and the advice from our next two panelists are probably going to be very important in making sure that we do this responsibly. So because of that, I don't want to take too much time talking. So the two panelists that we have today are Dr. Michael Saag and Dr. Mary McIntyre. And rather than me messing up their qualifications, and I'll let them introduce themselves and actually kind of get us going and kind of talk about some of the issues. So I see Mary McIntyre, are you with us?
Yes, I'm here.
If you don't mind, go ahead and introduce yourself and kind of tell us about your experience, and also, give us some idea of where Alabama has been in terms of its coronavirus, of our numbers and where you see us going.
Good morning, everyone. My name is Dr. Mary McIntyre, actually Mary McIntyre. I'm actually board certified in preventive medicine, but I actually came to Alabama in the mid-80s, okay, with my husband as part of the National Health Scholarship Program, and we stayed. We're originally from North Carolina. We went to school in Nashville, Tennessee. Medical school, attended McIntyre, and we joined the National Health Scholarship Program in order to be able to afford going to medical school, since we were both from families. I grew up in the country in North Carolina. We have 4 children. They're all grown, but not necessarily gone. I can say we finally gotten the majority of them out of the house. At one point, they did not only leave, but they came back and they brought more with them. Okay? So we've gone from having 11 people in our home, okay, at the height of everybody being there, to actually just 4 of us. So it's a little bit different for us because we've always had a full house. So that's my background. I did rural medicine in rural Alabama. Actually went to the state, went to the Medicaid agency as the associate medical director and then the medical director at Alabama Medicaid. And I've been here with public health almost 10 years now. And it was actually where I was headed and wanted to be, but it took me a little bit longer to really enjoy what I do. And I wanted to give you all a little bit of information related to where Alabama started. And I'm just gonna say this, we started off a bit low. We had a lot of issues with getting materials to be able to even test with. There was the issue with the initial reagents that were received from CDC, concerns. Actually, we got information with our state lab prepared to be able to stand up testing relatively quickly in early March, only to be told to hold off. And then they came back a couple of weeks later to say, you can use the reagents that you receive in order to begin to get prepared to do testing. So we really quickly, once we got that okay, really it was within a week's time, which is really almost unheard of for a state lab to be able to start using a thing and validating a test and getting quality processes in place in order to be able to test. They work day and night in order to be able to do that 7 days a week, okay? And so they were able to begin that was early March. And so where are we now? We started off slow with the numbers because there were problems with the ability to test within the state. And it wasn't just within Alabama, despite what you all heard from the federal level. The ability to even now get the reagents that we need continues to be hit and miss. We will have reagents within the state lab, and then there will be issues. We get an order, or we may get enough to test for a day and a half. When we actually speed up the processes to be able to do them quickly, and then we have to drop back to a manual process in order to wait for the reagents to come in that's coming through a federal ordering process. And that problem, we've been informed based on recent conference calls with some members of the White House COVID-19 task force being present, that's going to be resolved quickly. I will believe it when I see it, and hopefully that's the truth and the fact. But right now, as of right this minute, we're still dependent upon when the reagents come in to be able to continue to get the testing done at the state lab. So where are we today? As of 9:48 this morning, we had 10,494 people confirmed with COVID-19 infection. That's the SARS-CoV-2 virus. We have at least, and this is why I say at least, because we know we're not getting every single laboratory within the state to send us every negative test that's done. We have been fighting almost to get the positive results from the laboratories that are not, when the procedures are being performed, not at the state lab. We've got, we actually identified every laboratory that had submitted and called every single one of them over the last week or so to try to make sure that they understand that by the regs that they are required to submit all negative and positive test results to us, not just positives, but that still requires somebody identifying, because even this week we're getting new people coming on the scene to be testing. So that requires somebody currently trying to identify who is actually submitting positive results to then go back and see, well, did you have any negative results? And if you did, to report to us. So we've got 135,000 and a little bit over as of this morning at 48. We know that we've had reported at least 442 deaths. And once again, I say at least. The state of Alabama is one of only 2 states within the nation that don't have access, public health, to a healthcare discharge database. It's us, and I want to say Idaho is one of the I's, either Idaho or Iowa. Okay, Alabama and us. Other states have access to the ability to get access to their inpatient hospital data so that they can actually look to see and actually get discharge information to see what, from the standpoint of diseases, deaths, all of that info. We don't have it. And so people have been really, have the problem as far as a disadvantage in what we do have access to. There have been more than 2,600 hospitalizations within this state based on the reporting and information that we receive. And the numbers continue to climb. If you all pay attention based on what was there yesterday, based on today, the numbers are not decreasing. Our numbers continue to go up. And we actually have seen, depending on some specific counties, some really specific or significant increases when it looks at death rates, because people did not report the deaths. It's not so much that people just started dying faster. Folks didn't report the deaths and then send them in like 12 at a time, you know, instead of identifying and submitting them when they were occurring. And since we can't pull from a database system to actually identify that, we have to take what people give us. So that's where we are. I wanted to also talk about some changes, if it's okay with you, from the standpoint of what we've done to increase testing, especially in our population.
Absolutely.
And I've been on the conference calls with the Black mayors every Monday for I think 6 weeks now. I've also been involved with some of the ministers, the ministerial allowances, talking to them about what can be done for our population, the most vulnerable, since we are dying at a faster rate than anyone else. And that's nationwide, not just in Alabama. We see the exact same pattern. And some of that is, and I wanted to go into that, is for the fact that our population, we have a lot of issues with underlying medical problems. You know, we have a higher incidence of hypertension, cardiovascular disease, diabetes. You talk about stroke within the state of Alabama and in the nation as a whole, because folks with underlying medical conditions have a higher risk of complications, and thus a higher incidence of death as it results to COVID-19. So what we have been trying to do is to work to figure out what can we do to get increased testing available within the state, and especially within the populations that are most at risk. We've been working with the Housing Authority. We've done a pilot with ASU, the Alabama State University. That's gone well. We're going to continue that. We went into Patterson to work with the Patterson community. We're working with Tuskegee University and actually partnering with them to get some community testing involved. I've spoken to Pastor Ruggles, that with a ministerial alliance of like 50 or 60 churches, they're planning to do anything. And we're getting information out to them. We promised the mayors that we would give them materials that they could hand out ahead of time to let folks know when there would be testing available within their communities. As a health department, we've got our county health departments doing what we call drive-through clinics, which means the person doesn't even have to get out of their car. They can actually drive up, the paperwork is completed for them, their specimens are collected, and then they're sent to the state lab for testing. In addition to that, we talked through with trying to do some of that same, expand that concept so that we can get into some of the smaller rural counties to get more testing done. And if you look at the numbers, you can see we've started to get some gain in some of those smaller areas where we're getting some increase in testing. And the last thing I want to tell you about is we did expand the testing criteria so that a person without symptoms, asymptomatic, that has underlying health issues, diabetes, cardiovascular disease, immunocompromised for any reason, like with cancer, those kind of things can actually get testing done. They don't have to have symptoms. Any people within long-term care facilities, regardless of whether they have symptoms or not, if there's been at least 2 people, whether that person was an employee and a patient that tested positive, can be tested. That means it opens up testing to that entire facility for the people to be tested. The last thing that we did to make sure that we open up the ability, a lot of providers throughout the state, even if they're not using the state laboratory, actually, there are a number of commercial and clinical laboratories like UAB that are doing testing. They had issues getting the kits. We call them specimen collection kits or SCKs, but they're the ones with the swabs. that you can actually then collect a specimen and then submit it to a laboratory for testing. Those are the specimen collection kits, sites, which are what we do with our drive-throughs. We open up anybody that's a healthcare provider, whether it's a hospital, a private physician, a community health center, the FQHCs, that they can call a number to actually get these specimen collection kits so that they can actually also increase the numbers that are getting tested. And they don't have to pay for the kits. All they have to do is call the number, and I'll give that number if you all need it. All they have to do is call the number and ask and say, I'm Dr. So-and-so, I need 10 kits so I can have on hand to test my patients. So I can test patients. And we will, either they can pick them up or they can arrange for shipping of those kits. So that's where we are today. So we've come a long way.
Great.
It definitely sounds like that. And I'm going to ask you just a quick follow-up question, and we're going to open it up so everybody can get an opportunity. Basically, is the testing issue a state resource issue, or still a lack of availability of reagents, swabs, and so forth? Meaning, the state of Alabama, are we providing enough resources to get the tests and so forth, or is it still just a supply chain issue?
It's predominantly a supply chain issue. Right now, it seems from the standpoint of swabs, and I didn't mention this, in the very beginning, we couldn't even get swabs. It took us 3 weeks to get swabs, okay, within the state. And that was, we called everybody. We were calling the federal government. We were calling every vendor we could think of, but then the vendors had been told not to sell to the states. And basically the federal government was pulling in those swabs. So it was like, and then we started pretty much competing against each other from the state standpoint and trying to figure out how do we get the swabs. And that was an issue. Right now, we're in good shape. Now, I don't know how long that will last from the swab standpoint, have been worked out. The other issue we ran into was the transport media. It's called viral transport medium, or VTM for short. When you collect this swabs, you have to stick it into a media that allows it to be transported so that it will be still able to be tested, okay? So we couldn't get the viral transport media. Our laboratory, as they are really great at doing, we're able to get a recipe and start making the viral transport media. In the beginning, that's all we had access to. We couldn't buy any anywhere. No matter where we called, none of the manufacturers had access that they would give it to us as from a state standpoint. They were all going to the federal government as far as, I guess, they were supposed to, I don't know. So that was the issue with that. So we worked that out and figured out, well, we'll make our own. So, but that process itself, with them also trying to do testing, we can only make so many at the same time. And the facility itself was built in 1970s. We have a new one that hopefully, when things calm down, that's been built or being built in Prattville, that we'll be able to move to, but this is pretty much slowed even that process down. But right now, they are able to get the VTM, we can get the swabs, we can get the ice packs and the kits for people to be able to ship us that stuff. What we can't get, and that we'll still run into issues with, are the reagents that the laboratory has to have to do the extraction process for the testing once the specimens get to the lab. Now we have it, but it's not at the level that it needs to be. The federal government has assured us that we're on the list to be able to start receiving those where we should not be running out. But we've had a couple of times where we've actually had to send testing, and we do have contracts, or not contracts, but agreements with some commercial laboratories so that we can actually send specimens to them. That for people to test for this, they are highly trained um, technicians from the clinical standpoint of microbiologists, and we have so many of those available within the health department right now. But we have been able to pull folks from doing other testing, get them trained with these processes, and that's how we've been able to increase testing capacity.
Thank you. Thank you. I have a question, Dr. McIntyre. When you mentioned having access to hospital database, is that a statute that we must put in place? If I recall, I served on the health committee, and there was a bill that was introduced,
Yes,
and I'm not sure if that was the bill to address the issue that you mentioned. Is that the case?
It is, and I'm gonna say this. People know that this is on what I call my, not necessarily my bucket list, but on my must get done. I have must get done before I go home, or it was anyway until COVID-19 came along. I don't know. I'm gonna try to hang in here as long as I can. But for 20 years, okay, 20 years, it's been a little bit over that. I've been one of those people that's been a champion to try to get Alabama, what I call moving into this age, instead of leaving us way back, by getting a healthcare database access. And that bill is something that we work with the Alabama Hospital Association to get up. We really need the ability to do that. It's hindering us with our ability to get funding from the federal government because we can't give them the information that they need. It has hindered us in this response to being able to report information that people want because we don't have access to it. And like I tell people, we can give you information that we have available. It takes a whole lot longer to figure out how to rig something up to be able to get that when it's not already automatic and electronic. Okay, and we've done, I think our staff have done an excellent job in getting that and putting that dashboard on board, but it's taken probably 10 times or more of the work that was required to do that wouldn't have to have occurred if we already had access to information. And people don't understand it. They don't understand, well, why can't you do this in the state of Georgia can? Okay, well, we don't have access to information that the state of Georgia has access to. We don't have access that Tennessee has access to. So yes, ma'am, it is extremely important, Representative Hall, that we get that bill passed.
Well, I know we didn't get it done during this session, but what were some of the major pushbacks for making this happen?
Over the years, and I'm gonna say this, I think the biggest concern and the issue has been how the data would be used. Over time, more and more states have actually gotten access to the data. One of the things that I've been doing is working at the national level with people to explain, well, how do we use the data? We can assure that there's a process in place that is used to, guess what? Identify, first of all, where the health issues are within the state of Alabama, which we can't do because we don't have access to a lot of real data. We have access to survey data, questions that you ask on phones, that kind of thing. And we kind of pool and do other stuff to address specific issues. But we really can't go in and tell people for certain we get asked about lung disease, heart disease, those kind of things. The information we have is based on either samples, random done, information pool with certain researchers that do it, but we don't have a statewide database. So the main issue was initially from the hospitals about, well, what you gonna do with it? Are you gonna tell people what our quality is? But we've already gone through a lot of that now with the healthcare associated infections and the reporting over the years that occurred with that. And everybody has actually whipped that data, been able to improve their processes. So I think that was it in the beginning was, well, what are you gonna do with it? Is it gonna impact that hospital negatively and that kind of thing?
Good, thank you.
You're welcome.
So Representative Clark. Representative Clark, Adeline.
Good morning, everyone. Actually, good morning, Dr. McIntyre, and let me thank you on behalf of the Democratic members of the Mobile County Legislative Delegation for the assistance that you and Dr. Harris gave us in ensuring that we had testing in our districts where the number of cases, the number of deaths are so high. We appreciate all of the help and the guidance that you gave us, and you all made sure that we got tests for Franklin Primary Health Center, which serves many of the constituents in our district. So thank you so very much.
You're welcome.
And actually, Representative Hall, you proceeded to ask the questions that I had about the database. You did an excellent job, so thank you.
All right, thank you. Any other questions? Dr. McIntyre, we really appreciate you taking the time and spending this time with us.
Representative Hall, may I say something,
yes,
please?
Sure.
Good morning, Dr. McIntyre.
Good
This
morning.
is Representative Peblin Warren. I just want to personally thank you for the personal treatment that you gave me during my little crisis time there and assuring me and just, I mean, it was just magic. I just want to say thank you so much. I really appreciate it. And I just appreciate the entire staff, public health, as how they've handled this situation in the state of Alabama with the resources and the time that you had to do with it. So again, my sister, thank you.
You're welcome.
Yeah. Well, you can tell the ladies on here are real excited about seeing you there and the work that you're doing. So we are most grateful for that. Any other questions, Representative England?
I don't see any. Go ahead and we our other panelist is on the call with us now.
Okay, all right.
As I mentioned earlier, it's Dr. Michael Saag. Dr. Saag, are you with us?
He's on mute.
Okay. Well, he is on the call, and we're going to try to get him in. I think he's ready now. Dr. Saag, are you on?
What would you like to see us as legislators do with the federal dollars?
I think he's on the call, but I think we're on his call too. Dr. Saag? All right. There, we're getting. I think we're getting there. One more time. Paging Dr. Saag.
He's on mute again.
I'm somebody.
Okay.
No, he's.
Hey, I hope I'm not causing confusion. I'm not Dr. Saag. I'm one of the other panelists. I'm Kent Davis, Commissioner of Veterans Affairs. I just tuned in a little early.
Okay, we'll get to
Okay.
give it a little bit. We'll get to you in a second, okay? All right. Well, while we're trying to take care of those technical difficulties with Dr. Saag, do we have any further questions for Dr. McIntyre?
I have one for her.
Yes, ma'am. I unmuted myself.
Okay. In addition to the hospital database, if you could wave your wand today, what would be and utilizing the services that those of us that serve as legislators, what would be your top priority? And I also think about in terms of how the funding that the state is receiving would be spent.
Yes, ma'am. I'm gonna say this. You all, if you've looked at anything with the numbers with the states that with the staffing, we over the years have gone down. Okay, and then from the public health standpoint, with the number of staff that we have on board, this has proved to be very challenging from the standpoint of being able to do what it is we do. And the staff, our employees, when I say they have gone over and beyond with what we have, they have. They've worked 16-hour days or more. They've worked 7 days a week. The people at the lab, because they're not huge numbers and they're specialized as far as the microbiologists, have to work, the ones doing the COVID testing, 6 to 7 days every week, because they can't take off. There's no way for them to do that. and for us to be able to meet requirements to get testing done. The same thing now is we really need to be doing contact tracing more. We're doing it with the staff we have. We're not doing it as timely as we want to do it. And that is calling people that when we identify them as being positive and identifying who they've been in contact with and close to, getting to those people and making sure they have instructions on what not to do and what to do. Okay, are they symptomatic? Do we need to get them tested? Are we getting all of that process? And so what we need is we need the resources, the IT processes. We're putting in some IT stuff from a contact tracing that will help so that we don't need as many people, but we still need bodies. We need folks. And we went in and did some initial numbers. You know, some states have gone, like New York, I think they had 1,000 more, or some people with to do contact tracing. But we know that that's not feasible and really not necessary, but we do need several hundred more to assist with just trying to get to people and explain to them how to protect themselves. So that's the biggest ask from the standpoint of what I see that would make the biggest difference. I don't know how long we were going to be here as far as in this role, but we've been told to expect a second wave. We're not out of the first wave, okay, yet. So, you know, that in itself is scary. And then we've got people, unfortunately, retiring. So we need to be able to replace them, but to also hire additional people to be able to continue to deal with this. And the next thing that comes up, you all know that we've dealt over the last few years with a number of diseases, Zika virus, that impacted women, especially that were pregnant, with increase in birth defects in their babies, that we had to actually get we didn't have access to a database then, that we were, when it came down to congenital defect tracking. So we were able to do that based on that last event, but it's also kind of retro. You know, something happens, we don't do stuff necessarily proactively and it to look for the next thing as a state, but right in the middle of it, then we deal with it and we put some things in place. We would love to be able to plan ahead, to have the resources to do that.
Excellent, thank you.
Thank you, Dr. McIntyre. Now I think we've got Dr. Saag on the call. Right?
When I get up here. Wait till I get off here.
Yes, hi, sorry, my wires got crossed on timing, so apologies for being late.
Just like Dr. McIntyre, I know y'all got a lot of stuff to do right now, especially considering that despite the fact that our case numbers are going up, we are opening everything up. So I know y'all are very busy and probably worried just like the rest of us are. But if you don't mind, a lot of people know who you are already. And for those who don't, could you introduce yourself, kind of tell us about yourself, you know, and what you've been doing, what you've done, and kind of give your assessment of where we are as in Alabama with the current pandemic.
Great. Thank you very much, and apologies again for being a little bit late. So my background, I am an infectious disease trained investigator, trained at UAB. I'm still at UAB. I started the 1917 clinic, the HIV specialty outpatient clinic, back in 1988, which linked not only patient care with research, but also a lot of community outreach, and that's continuing to this day. About 10 or 12 years ago, I got involved in hepatitis C, and I think we're getting that under control. And now that this COVID epidemic has hit, a lot of us are throwing our efforts into that, and I'm sort of right in the heart of that. A little bit more background, I've gotten so involved in it that I actually picked up the infection in mid-March, early March. It was not, it was a very unpleasant journey. It's given me a lot of respect for the infection and what it does, and also what people go through when they're experiencing the infection. But to segue over to the issue right now at hand, is, as you were alluding to, we're in the middle of a major pandemic, and this is affecting the entire country, but Alabama in particular. I think the public is getting a lot of mixed messages from both the government, but also the news, and it depends on where they get their news in terms of what their perceptions are, and that unfortunately is breeding a lot of mistrust because because of the conflicting messaging, the actual facts about the infection are somehow getting lost. And I think it's incumbent upon all of us to pull together on this and try to create a consistent, fact-based approach to providing information. So with that, let me, if it's okay, I'll do another 2 to 3 minutes just on the facts about coronavirus. Number one, yeah. Okay, so number one, this is a virus. Let me close the door so I don't get background noise. This is a virus we've never seen before. It's not been in humans. It's related to other coronaviruses that do infect humans, but it's different. We know that this virus is very contagious. I mean, very contagious, much more than flu, much more even than the common cold in all likelihood. We know that once it infects somebody, it can take about 2 to 4 days for symptoms to develop, maybe 6 days, and that the course after infection is highly variable, such that some people don't develop symptoms. That's maybe 20%, and the other 80% can have mild to moderate or even potentially severe disease. And the severe disease is the one that you see in the hospitals that ultimately require people to go on ventilators, and unfortunately, people to die. And the part that is confusing to me just as a human being is how the country and Alabamians, a lot of us, are not comprehending the notion that there's 2,000 to 3,000 deaths a day. And I lived through the Vietnam War era, and there was never a day that Walter Cronkite came on and said there were 3,000 deaths in the Vietnam War today. That didn't happen. But that's what we're experiencing now. And the country, I think, initially came together around the notion of some degree of stay at home, flattening the curve. But now the country, a lot of people are saying, we've had enough. We want to go back. Let's just re-engage. And I'm all for that, provided we have a plan for how we're going to do that, as opposed to just saying, all right, let's take out the control rod from the nuclear reactor and kind of see what happens. We know what will happen, and it's starting to happen now, and that's what concerns me a lot. What we need to do, not only as a state but as a country, is as best we can come together with a common plan forward. And that plan, in my mind, has the following principles. Number one, stay at home until the plan is fully developed, which shouldn't take all that long, but we need a little bit more time. The plan itself would involve more widespread testing, because without testing, without knowing who's infected, we're basically flying in this epidemic blind. Worse, we're flying in fog blind. And we're not going to be able to know where we are or how we're going to land the plane without information. And the best information we can get right now to see what's going on is testing. Once we get testing, then we can do a lot of very important things. One of which is if we identify what we call an index case, someone who's infected, then we can identify the people who have been in their local environment in the 24 hours, especially before they got symptoms. Why? Because during that 24 hours is when the peak amount of transmission happens. So someone can be totally asymptomatic. They feel great. They might go to a restaurant or go to a ball game or whatever they're going to do, go to graduation, which is happening in a couple of school systems right now. And they'll sit and they'll be spewing a lot of virus into the environment, not intentionally, just unknowingly, and the people around them don't know. And during that time, a lot of other people around them get infected, and this is what creates exponential growth, and we're seeing that. So the advantage is that if we identify that index case, find the people around them who might have been infected, test them, and see which of them are infected and pull them out to more of an isolation status so they're not infecting others in the environment. This is not anything complicated. It's in essence public health 101. It's almost like going back and learning the alphabet if we were in school, learning how to read and write. This is the building block of public health. And it's been done elsewhere successfully. South Korea is a great example, but Germany, Israel, Iceland, Austria, a number of countries have done it, but we haven't. And that's very frustrating to me and a lot of people who I work with in the public health sector. I want to have questions, so I'm going to wrap up with this and just say, to me, what's interesting is that when I look at TV and I hear colleagues, and there's a lot of, quote, experts, and they are, on TV, without any collusion, without any talking to one another, we all say the same thing. If you just think back to the shows you've seen over the last 2 to 3 weeks, there's a different talking head on television, but we're all saying the same thing. And why? Just because it's the truth. And it's that simple, and it's that basic to what infectious disease doctors, epidemiologists have done from the beginning. It's 101, as I said. So now the question for us, the hard part, is how do we take these very basic principles and implement them in a way that's effective for the state so we can begin to go back toward normal, but with a virus in our midst that frankly isn't going anywhere soon. It's not going to just disappear because of the heat. Sorry, that ain't going to happen. It's going to be with us for the summer. It'll probably be with us into the winter, and it may be with us by this time next year. So we need to get our head around that and start making plans on how we're going to manage it and not let it control us. So I'll wrap up there. I hope that's kind of what you wanted, and happy to just take questions.
I'm pretty sure there's going to be a bunch of them, and I'll go ahead and kind of get it started.
Okay.
With reopening, you're starting to give people the impression that we're on the opposite end of a wave. In your opinion, have we plateaued? Are we beyond? Are we at a point where we can say we're looking toward the next wave, or are we still embroiled in the first wave, so to speak?
Yeah, that's a really good question. I think what happened was we started going up and we did plateau. And if you really look carefully, different counties in the state are different stages, right? So some have plateaued. And then if we take the restrictions away that sort of enabled that, it's going to go right back. It's starting to happen already. And so what we need, and the reason is, and I'm not trying to take shots at anybody, I think what we're missing is the testing capacity to do this in a way that's in accord with standard public health measures. And at UAB, we're working on expanding testing capacity rapidly. We're not quite where we need to be, but there's a lot of progress. For those of you in the Madison County area, Huntsville, Hudson Alpha is being brought into the fore. So we're going to expand that. We're also working with the state health department, in particular Scott Harris, who is really got his eye on the ball and is trying to do the right things. So we're working with him. We're also working with a lot of county health officers and region health officers to try to implement this. But we just haven't had enough time to really get a comprehensive approach together. It's gelling now, but I think we're 2 or 3 or maybe 6 weeks ahead of when we should be retracting, because it'd be much better to do that with these other platforms in place that will allow us to case contact trace.
Thank you. Okay, Representative Hall, what do you have? Do you have any questions?
Yes. And so, when you think, Dr. Saag, it's always good to see you, and that you're
Nice to
still
see you.
working at a time. I guess a couple of things. One is you indicated what you thought would be a common plan in such as stay-at-home, widespread testing, in the index case. And so looking at the funding that we're receiving for the state, tell me how what that would look like in terms of funding, and what do you see our role in terms of helping you and others that are working on this pandemic to reach this need hastily?
Well, thank you, Representative Hall. It's good to see you as always. So let's start with the basics. No state has the funding in its coffers to deal with this on its own. And we can do something, but the demands of testing are so high that even New York needs federal help on this. Fortunately, the federal government in the last Relief Act that was passed pulled out about $25 billion to help states respond. Those monies, as I understand it, I think a lot of it's going to CDC. And what I would hope happens is that funding then goes ideally to the state health department and then can be distributed to trusted partners throughout the state to implement a plan as it comes together. That's one approach. It may be that the dollars will go directly from the feds into the state coffers. I don't know how that would work. You guys would. But what I would implore us all to do is to try to get on the same page, buy into a plan that we think is going to work, and then make sure it gets funded so that it can be implemented not only well, but quickly, because this virus isn't waiting on us. It's moving on. So I'll let you ask a follow-up because I'm not sure I fully answered your question, but what you can do is we can work together in terms of communicating, just like we're doing now, and discussing what the plan might be and how we should fund it.
That's good. That's fair. Thank you. I look forward to our talking more about this.
Great, thank you.
I guess I also want to ask you a question. I'm thankful that you went through that ordeal and you're still with us. As you said, a lot of people say the same thing. So we're thankful that you are still, still here in the fight with us. But one thing that I think is on everybody's mind is that there's been some stories out there that indicate that we're not necessarily sure if you develop some sort of immunity to this disease after you contracted it the first time. Can you enlighten us on that? Are you
Sure.
confident, or do you believe that we develop a immunity to it after contracting it?
Yeah, I hope so. for personal reasons, yeah, but also for all of us. So here's what we know, and I'll just start with me. So from day one, after I started developing symptoms, I volunteered for a research project where they drew my blood, and as I was confirmed to be positive, they'd drawn blood every 2 weeks thereafter. And it turned out for me, my antibody levels are super high. I think the highest that they've ever seen in the assay at University of Pennsylvania, where my colleagues from UAB transferred a few years ago. So we're still working together. So what I did is I went and donated 500 milliliters of plasma and 5 billion cells for research purposes to see exactly what the answer to this question might be. And we don't have the answer yet. But my belief is, and underscore that word, is that we will have a protective immunity. And that opinion is based on other viral diseases that are like this, where we do have such protective immunity. The thing that's giving us all pause, and I think if you watch Dr. Fauci's answer to this question yesterday, we can't know for sure until enough time goes by to see if someone like me or others who've had it before get reinfected. If that were to happen, if we do not have protective immunity, we're all in deep, deep trouble, because that means that there won't be the herd immunity that some people talk about. There probably won't be a vaccine, because if infection itself doesn't lead to protection, How is a vaccine going to do that? So to take us out of this negative pit, I really do have a strong sense that immunity will be protective. And then the question would become for how long. Based on other diseases, it's at least likely to be a year and could be up to 5 years, maybe longer. But your question gets to the heart of how we're going to get out of this epidemic, because without protective immunity of those who are infected, we're really in trouble.
Yeah. Thank you. Representative Adeline Clark has a question, and following her question, Representative Anthony Daniels has one. So Representative Clark, you are recognized.
Thank you, Representative England, and hello, Dr. Saag. I saw
Hi.
you on national news and was very impressed. You made Alabama look good, and you don't always do. So thank you. I have two questions quickly. One, how do you rate Dr. Fauci on yesterday when he testified? Did he do an excellent job?
He told the truth. Yes. He'll always, I've known him for 35 years. He is not only smart and articulate, but he's a good person. He's a type of person who serves us in government that we should all be proud of. I mean, he could have gone anywhere. President of a university, could have been president of Harvard. He chose to stay and serve us at the NIAID. So yes, and he will always speak the truth and will speak truth to power, always.
Thank you. That's the impression that I have gotten each time that I've heard him. You're the first individual that I've come face to face with who has been infected. Will you, as a medical professional, describe, were you hospitalized or were you quarantined? And will you describe how it feels? I mean, we've heard some news bites from patients, who've talked about chest pains and certain other things, but will you tell us how it feels to have coronavirus?
Sure, happy to. And I wrote an op-ed for the Washington Post that I'm happy to circulate that does this, but briefly.
Please do, I didn't see it.
Yeah, first off, the course is variable for everybody. So if you've heard one case, you've heard one case, but I think my case is pretty typical. So I got infected. I know from which exposure. Within 2 days after exposure, I started developing a cough and a headache and just generally felt bad. No fever. Day 3, I got tested. By day 5, I thought I was done with it. I felt great. And I thought, okay, that wasn't so bad. Let's move on. That night is when all hell broke loose, and I had chills and fever and headache and worsening cough, and just felt like I'd been hit by a truck, couldn't sleep, and had fuzzy thinking. I don't know how to describe it, but I just couldn't concentrate. I couldn't focus. I didn't have chest pain, but a lot of people do. I didn't have diarrhea. A lot of people do. I did lose my sense of smell, which is kind of common. And that would be that first night. By the next morning, I felt okay. I thought, all right, well, that wasn't so bad. The next night, boom, it's right back. And this went on, that pattern, good in the morning, horrible at night, went on for 8 days in a row. And I had no clue when it was going to end. And I had, in those worst moments at night, no clue if this wasn't going to worsen and I'd be up in the hospital on a ventilator. That was the horror of it. And especially as a provider, because I knew what was coming if my symptoms got worse. And that's the nightmare. I call it the Rod Serling experience of the Twilight Zone and just this horror coming at me during the night. So fortunately, it ended one day, the 14th day, I woke up, felt good again, held my breath into that next night, and it didn't come back. But something else you're going to hear more and more about is the recovery phase. I just got off the phone about, actually part of the reason I was late. A doctor friend, colleague in Memphis went through this. His symptoms ended 4 weeks ago. He was calling me just now to ask me, did I have residual symptoms? And I said, yeah, a little bit. When he's experiencing bouts of fatigue that just come on like that in the middle of the day. Boom, just has to sit down, maybe take a nap. And the second thing is, every now and then, he just can't think straight. It just hits him. So this is a systemic illness that is horrible. And you don't want it. Trust me, you don't want to get this.
Thank you for sharing your experience.
All right, Representative Daniels, the floor is yours.
Thank you, Mr. Chairman, and thank you, Dr. Saag, for what you're doing to really change and really bring awareness in our state and on a national stage. My question is, we're seeing so many people of color across the country, really, but particularly in Alabama and most of our urban pockets, contract this virus. But in many instances, we've been told that the underlying health conditions also makes people of color more of those that have passed, that have died, is because of some of the underlying condition. But I saw where 5% of the people that died had no pre-existing conditions or underlying health conditions. If you can wave a magic wand, what type of research or things that you think we should be doing besides educating the public on sheltering in place, but particularly in communities of color, is there any type of treatment that's working out there? Are there things that, should we be doing research and gathering data right now instead of waiting for an after action report, trying to figure out how we're able to treat people of color in a different way? Just help me understand what would you do, particularly in communities of color.
Yeah, thanks. Your question is spot on and very accurate. And it is a mystery why people of color are having worse outcomes. It's not, I'm not sure they're being infected at necessarily a higher rate, but when infection sets in, the clinical course is typically much, much worse. And the bottom line answer is nobody knows. What I can tell you, so to answer your question about where the research needs to go, I'll just pick 3 areas. To your question, we need to know how the virus causes disease. And we know that it has to do with an immune system response. So the virus itself doesn't really cause symptoms, the replication. What causes the symptoms is the immune system response to trying to get rid of the virus. So those periods at night when I was so sick, that was my immune system trying to knock the virus out. And in the morning, the immune system kind of takes a break. And that's why I felt better. What I think is happening in the people who have more progressive disease, and that would be a lot of people of color, is that their immune system is hyperactive. It's just overboard. And that extra effort could be exacerbated by an underlying condition like hypertension or diabetes, perhaps obesity. Those are the things that are talked about the most. But the bottom line is we don't know, and we should be studying it. So that's number 1. Number 2, we need desperately a treatment. So we have remdesivir, and that's an important step forward. I don't think the hydroxychloroquine, the Plaquenil, it's not good enough. The remdesivir worked in people who were very advanced disease, but it was used so late in the course that some people, their pathway with the immune system and the damage done was already so great it was just not enough to save them. Others, though, it did prevent them from going on a ventilator and reversed. And the reason that would work is that the virus is simple. It just wants to replicate. And so when you give an antiviral, you stop that replication, and then the immune system has a better chance of mopping up. It's like the infantry on the ground with the air support. The air support is provided by the drug that stops the replication, and then the immune system is the infantry that cleans up the mess on the ground. That's kind of how it would work. So remdesivir, though, isn't good enough because it's IV, and so you can't use it early. And it also is in short supply right now. So what we need is an oral drug that works like remdesivir, and here's how I would see it being used. If somebody got a symptom today, within 12 hours, I'd have them on this drug before the virus could take hold, before the immune system gets out of control, and just abort the infection and we move on. That's what we need. So that's the second area. And the third area that you've heard a lot is vaccine research, and that's moving on, and it's pretty remarkable. I know a lot of you personally, and I know a lot of you suffered through the HIV epidemic. And if you think about AIDS, it was described in 81. The virus wasn't known until 83. The test wasn't available till 85, and a treatment wasn't available till 87. That's 6 years. We're 3.5, 4 months into this epidemic. We know the virus. We have a test. We've already got a treatment emerging, and a vaccine candidate was developed on January 16th, 1.5 weeks after the virus was first really described. That's amazing, right? So there's hope, but there's equally 100-fold, 1,000-fold more questions that we need to answer. Good news, a lot of researchers are looking at this, and I hope very soon your question about why people of color are disproportionately getting more sick can be answered.
Yeah, I particularly see that times we want to do after action reports, and after action reports in many instances are too late, and when we can focus on trying to save lives right now. The other part of that is, you know, we hear about people that have these underlying health conditions, but it's apparent to me that there's not been any data that talks about if I'm, you know, somebody having diabetes and one person is being treated for diabetes, whether they're on the shots or oral, and they're controlling their control versus a person that is not controlled. You know, does this disease feed the same way in both instances? So those are like questions that nobody could tell me the answer to. And so I'm just trying to see what, if we were making recommendations now dealing with some of the federal funds that's COVID related, what would you advise us? It's particularly one part of the question is for communities of color. What would you put together? What would you advise us to put together in order to really address communities of people of color and those underlying health conditions versus overall, what would you spend dollars on to really help fight this disease long term? So it's two things, two recommendations, because we want to make recommendations, but we want to make certain that we are saving lives in the future, but not waiting to for an after action report to act.
Yeah, I hear you. One of the things that I think helps, and we're doing it in a lot of other places, is real-time tracking of the case and following the outcome and collecting all the information so that can be analyzed in real time to see what are the factors that put someone at higher risk for progression. That can be ongoing. Meanwhile, just like what I did, as soon as I got sick, I volunteered for a research study. I started donating blood. That blood went immediately into research laboratories that are evaluating the immune response. So I think working together between capturing data and drawing specimens that can be evaluated, that can get to the heart of answering the question as fast as anything we can do. The other part, longer term, is to think about as we're getting clues from this basic science and following patients and getting the information, is that we can also be thinking about any interventions that might be suggested by the pathogenesis, how the virus is causing disease. So, for example, one of the things we discovered early on was that certain immune chemicals go up high as people get sick. Well, we have drugs that can cool off the immune system. You've seen them advertised on TV for arthritis or for dermatitis, psoriasis, whatever. Those medicines can be used, and they are being used, and they are being tested. And it could be, again, like I said, the immune system is just going haywire that causes people to get sicker. Let's cool that off. And so those studies are already underway. So hopefully we're getting to answers quickly, but obviously not quickly enough for the people who are suffering at the moment.
Okay, and so if you can provide us with the names of any individuals that are doing this type of work on both sides of this, so that they can be a part of our recommendation for additional funding, because I'm certain the funding is an issue with even those groups that are work. So thank you.
Sure. Thank you.
Any other questions? I think Representative England probably got knocked off.
Well, this is Representative Drummond. I have a question for Dr. Saag, if I can, please. Dr. Saag, in listening to the answer that you just gave to Representative Daniels, I'm in Mobile, Alabama, and we're right now a hot spot with growing numbers. My question is because we're going through our hospitals, our independent living centers, and our nursing homes. Is there any way that you think in Alabama that we can put some of those federal dollars to a unified data system? Because, you know, I've heard nationally and I've heard so much talk about we really will not know what those true numbers are, because there were a lot of people who had coronavirus who may have healed and went home and so forth and so forth. And none of these entities are talking to each other, even on the Alabama Public Health side. So can you talk a little bit about that, please?
Yeah, sure. I think that's a critical question. I would think of a place to start might be with the state health officer, with Scott Harris, and we've been working together a lot. He's been working with UAB. I'm pretty confident he's working with the University of South Alabama as well. The notion is that there is a national way of tracking. The problem is, how do we know who's infected and how do we know it's being captured? So that comes right back to that root word, testing. And testing in an organized way, and then having the reports come in and the data being captured, processed, and you can identify hotspots. So let me kind of give you a vision of what I think is going to happen in the next 4 to 6 weeks that will address, I think, your concern. UAB is working with the health department, and we're trying, and other entities, to try to create a platform where more universal testing is available. So let's take your examples. The nursing facilities, where we know those are hotspots. Test everyone in that nursing facility at one time. Find the people who are positive and isolate them in a different area. Take those who are negative and keep them away from those who are positive. And then identify those who are positive, track them medically, and report their numbers. And do that institution by institution as we go. If new cases pop up, like say in that group that were negative originally, then we pull the person out again, but then we find all the people in their immediate environment and we test each of them again and see who's positive, get them isolated, and then monitor over 10 days who was exposed but apparently not infected right at the moment. And those types of basic principles of public health can be and should be, and I'm pretty confident will be applied. We're just not there yet. And the rate limiting step is testing, quite honestly. Meanwhile, I should have said this at the beginning, but I'll say it now. There are simple things we all can do. You hear social distancing, you hear these buzzwords. Let me describe what it means. We now know that most of the virus is transmitted through breath and through the oral expulsion of air. So sitting quietly breathing is not spewing a lot of virus, but talking does, yelling even more, and singing even more. So if we all wear masks everywhere we go, when we're outside of being at home by ourselves or sitting in a park alone or something, everyone should be wearing a mask for 2 reasons. One, it keeps the virus, if we have it, from spilling out into the environment. And secondly, it keeps us from touching our face where we might have picked up the virus from a surface and can inoculate ourselves. That's one thing. The avoidance of large gatherings is essential. It's critical because you never know in that closed-in group who's going to have it. We know that outdoors is much a better place to be than indoors, especially if there's a fair number of people. So when I get to the notion of reopening, like we're talking about and we're doing a little bit, going into a crowded restaurant is a really bad idea, especially when people aren't wearing masks. And I'm seeing that happen right now, and I'm sure it's happening in Mobile and elsewhere. We need to educate the public about these principles and get it done.
Thank you. Are there any other questions?
I don't think so. I think we're over. I think we have ended our time, Dr. Saag, Dr. McIntyre. We are grateful for your participation, and certainly if you have additional ideas or suggestions in terms of how we can best assist in addressing this pandemic, feel free to reach out to the minority leader and staff. Thank you so much.
You can reach out to me as well. I'm happy to answer any questions at any time. So the email I can get sent around, but please feel free to use me as a resource as you need to.
I wanted to mention one thing. I'm going to send it out, but we did make available or send out a harm alert out. That's a little thing that we send to all physicians throughout the state last week, where we apparently we had already sent it on the 24th, but people didn't get it, that we were recommending that asymptomatic testing for persons occur in long-term care facilities, and apparently folks didn't get it. So we did it again, and I put it at the very top as well as putting it in bullets to say all they had to do was to, if they wanted to use a commercial laboratory, that's fine to do the testing, but that we were recommended that they test people within those long-term care facilities, whether they had symptoms or not. The other thing that we made available, and this was last week, is the testing kits in initial, because we couldn't get the swabs, we couldn't get the media in order to be able to submit the swabs. We were really having to be really careful about who we provided those to. So we focused on the hospitals initially and making sure that they had sufficient supplies, or those any kind of areas where we knew we had an outbreak of issue. We now have adequate, I don't know how long that's gonna last, but I'm hoping it's gonna be from now on, supplies for people to get the specimen collecting kits. I'm gonna hit a button and it has a phone number in it. Any provider, whether they are in a hospital, a private doctor's office, a community health center, an FQHC, we're doing drive-through clinics. We've got folks that we're working with to help them set up drive-throughs, using where we can get the test done. They don't have to send those to us. Most of the commercial laboratories use the same biotransport media and will accept those swabs because we're using the recommended ones for testing. We do tell people to just double check to be sure, but all they have to do is call the number that's on here to be able to get access to those kits. It is 334, and this is for any kind of the doctor's office, long-term care facilities, 334-239-1556. We're trying to limit the max that they get to like 500 at one time, but that's a lot for most places, just to make sure that we can get them around. But in the beginning, we were limited to 10 and 20 because we had so few of them. Right now, we're in good shape. So get the word out, let doctors know, others know, FQHCs know. We sent the info out, but apparently those alerts don't always get to where they need to be, okay?
So thank you very much. Dr. Saag, Dr. McIntyre, we thank you.
You're welcome.
What was that number again, Dr. Matt?
We are not.
Let me hold on.
Are we ready? Do we have our next Dr. Beshear? Is she on?
Yes. Can you hear me?
Yes, I can.
Okay,
Thank
great.
you.
Well,
thank you, Dr. Beshear. Representative Drummond and I are coordinating this session. We are grateful that you are able to spend time with us this morning. What we would like for you to do is tell a little bit about yourself and talk about the issues and the impact of COVID-19 on the mental health concerns.
No,
Well,
Representative
Representative
Hall.
Hall, thank you so
yes.
much.
Yeah, let
Hold
me
on
just
just
say
a,
this before Representative Beshear comes on, is that, we've heard over the past 2 or 3 weeks about how Representative Beshear is #1 on everybody's list today, because from the school system to the jails to everything. So she is probably one of the busiest commissioners, and after sitting through a number of her presentations, we can see why, because she is an innovative leader that is attacking all of these problems. So she is the woman who is in the spotlight right now, Dr. Beshear.
Oh,
thank you.
gosh. Well, thank y'all for those kind and sweet remarks. I will try to live up to them. And as we know, it takes the village, and we've got a village of hardworking folks, despite the fact that you are now seeing the backdrop in my dining room at my home, okay? So welcome to the Beshear home. I have prepared some responses to your questions because I wanted to be right on target and maximize our time that we have here together today. And I'm happy to take questions. And if it's something I don't know, obviously I will get that answer to you right away. But let me just remind y'all that our mission and vision are to serve, empower, and support individuals with mental illness, substance abuse, and developmental disabilities. And as you know, even under the best of circumstances, that's a challenge. And so when you layer on what we're all going through now, it presents us with some interesting character building opportunities. But we are rising to the occasion, as are our community providers. And so I want to share with you sort of where we are with that. And then I want to be sure that I answer all your questions. And the first question that I was given was, how has the COVID-19 impacted our agency? And first of all, we have 900 employees who work in our 3 hospitals. And y'all are very aware of our 3 hospitals, but many people in the state kind of forget that they are under the Department of Mental Health, and they're all up there in Tuscaloosa. And so we are following all of the guidelines for patient care and protection that are in place in every hospital. I was so gratified that for weeks, literally 6 weeks into this, 7 weeks into this, we had no positive cases in our hospitals. And that is a tribute, I think, to our workers who were following very stringent health guidelines, masking, PPE, and such. And you remember that our Harper Center is sort of like a nursing home facility, but our other 2 hospitals, the patients are ambulatory. And so we have challenges there with the distancing and the protection of that population as well. Unfortunately, within about the last 10, 12 days, we have had 4 positive cases at Harper Center. And none of them at this point are life-threatening. 2 of the individuals are at the hospital and being cared for there, but they are in stable condition, and our hope and prayer is that they will fully recover. We believe that these patients became infected through a nurse who tested positive, and she was a contract nurse with us. So there you have it. We have 900 employees in Tuscaloosa, and then our remaining employees are in the central office or are in our regional offices across the state. And they have been working at home. And then for those workers who absolutely had to come into the facility, the office, the central office or the regional office, it has been under guidelines of physical distancing and all of the measures to protect their health. Okay. Let me refer to my notes here a minute because I don't want to forget anything. Now, you may remember that Medicaid, CMS, has really relaxed some of the regulations in regard to people being able to provide telemedicine. So people who are getting therapy are able now to get it the same way we're having this conversation. It's not as satisfactory as in person, obviously, but it is certainly better than nothing. And many of them are really liking this. So it could be that portions of this could continue into the future of our system of care, which is a positive thing because it could help people who are limited by travel and allow practitioners perhaps to see more individuals in a day. Of course, on the other hand, as we know from many of our rural citizens, a lack of broadband is a serious impediment to getting therapy. And we know that it's an impediment for children who are trying to continue their studies online, and as well as an impediment for delivering mental health care. In cases where it is absolutely essential that a person have a face-to-face encounter with a practitioner, those arrangements are being made. Now, our day programs, excuse me, for people with mental illness and disabilities have been temporarily suspended, and people are being continued to be housed either in their personal home where they were living or in a group home setting. You may recall that the first person who passed away in the state from COVID was actually a recipient of services from our department. This individual lived at home. They had DD and were actually in supported employment services up there at the hospital in Jackson, not the hospital, the county commission in Jackson County. And we were so touched by the way the people in the courthouse announced her death. And they spoke of her with dignity and respect as though she were just another employee in the system there. And they did not identify her as being a special needs person. And that is what all of us are after, is for people with mental illness, substance abuse, and developmental disabilities to be treated with dignity and respect. So I just add that as a little sidebar that meant a great deal to us. Now, you had asked about what our plans are for recovery. And certainly, as we just heard from Dr. Saag, the importance of treating vulnerable populations, which we certainly serve vulnerable populations because of their diagnosis, is to protect them. We are establishing a 14-day quarantine unit up in Tuscaloosa for patients who have been referred to come into our facilities. One of the first things we did was to shut down new admissions, but we know that mental illness and substance abuse don't go away, neither do matters of through the court system that refer patients to our Taylor Hardin facility. And so we have established a 14-day quarantine unit so that we can receive patients from a community hospital or from a jail, but also ensure that they are not sick, and that our first duty is to protect the people we already have in the hospitals. So the reality is that this unit may have to be active for an extended period of time. We have just heard from Dr. Saag that we don't know when the end of this will come. And so we are going to err on the side of extreme caution in that way. I'm a nurse, actually. My husband is the Dr. Beshear in our family, and I'm the nurse. And so I'm very aware of the spread of infection and how it could go through a community like a Harper Center or Bryce or Taylor Hardin like wildfire. So we want to avoid that if at all possible. We want you to know that we are fully aware that the impact of COVID, particularly on healthcare providers, is going to go on for a long time. We have seen on television, played out in the news, the devastating effect that this is having on people who have to work in intensive care units and with multiple deaths a day and critically ill patients. That is going to take a toll. And the PTSD from that will not be seen possibly for months. So we are working with FEMA on a grant that will be targeted, if we get it, to provide for the long-term mental health of healthcare providers. Because if healthcare providers aren't well, the rest of us are certainly going to be extremely challenged. So we can't forget to take care of the people who take care of us. We have also been working with the State Department of Education to try to address the mental health needs of our students getting school-based mental health. It has also come to our attention through Dr. Mackey that other students and teachers are experiencing some issues. And so we are working to try to help address that. And of course, despite all of this, we are continuing the work with our consultant team and with our community mental health centers to try to stand up a system of crisis care in the community. If ever there was a situation that pointed to the need for that, it is this one. So we certainly have appreciated the affirmation that the House of Representatives and the Senate have given by keeping us in the budget. You have no idea, because when this happened, we just thought, well, that dream is over and the dream is alive. And I want to thank you for it. What do we need from the state, I believe, was another question that you had. And we certainly, as I said, appreciate the funding for the crisis centers and also the ability to expand school-based mental health. We know that children who have been isolated and in probably less than optimal family situations, many of them are going to have some psychological, emotional issues around this. So we are trying to prepare for that. Let's see, wanted to point out that our agency has not received any of the CARES funding. Our grant request that went in on April the 10th, that we had a team of people working on, got caught up in some sort of glitch, is what I've been told, as did other states. And so we did not get any of that CARES money. So we certainly would appreciate that. We have our community providers who are having to absorb costs for providing supplies. We have been able to provide some supplies from us shipment that we received to our community health centers and our DD providers, but it was just a drop in the bucket, but it was something. So we know that they are incurring expenses from that. We have also incurred expenses because we felt that because we were requiring people to go into a situation where they may become ill themselves at our hospitals, that we needed to provide a hazard pay. And so we have done that. Right now it's effective through July. And it's essentially about $400 additional per month. But that's got to come from somewhere. But we felt that it was an investment that we had to make. And so we worked with Jackie Graham at the state personnel to achieve that. And we know that other agencies have also done some hazard pay as well. Having said that, I will just open the floor. I know that my good friend Admiral Kent Davis is scheduled to come on after me, and I don't want to use up too much time, but I also want to answer any questions that I'm able to. So thank you for this opportunity.
Thank you, Dr. Beshear. Are there any questions? Dr. Beshear, you've talked about all of these agencies that you're working with, and we just finished talking about trying to create a unified system where, because say, for instance, the folks that you were talking about initially that have been doing telemedicine, they have children that are in school that are suffering from some of the same things. So would you benefit from a unified system if you sort of knew what those benchmarks were in the adults that would be transcended down to those children that are in school?
Boy, that would be great information. I tell you, that is such a great question, because we are data driven. We have to be. When we come and report to you about the expenditure of money, we have to be able to report on the details of that. And we actually have set up a central data repository that is through the opioid work. It's a whole separate body of work, and we went through a very lengthy process to identify all the players in that. And so we are already sharing data around opioid. And we are also in a very aggressive process of trying to stand up through our stepping up process data collection. Because if you're going to reduce the numbers of people with mental illness in jails and emergency rooms, you got to know how big of a problem it is. You have to know where you are so that 6 months from now, you can identify progress or not. So we are completely data driven, and any conversations around that, we would really welcome the opportunity to be a part of. We absolutely would.
Are there any other questions? And I can't see if you've got your hand raised, so if you just chime in and ask your question.
Hey there, Commissioner Beshear. It's good to see you again. Thank you again for coming on. My question's pretty Hey there. So I know that many of our state-funded rehab programs have struggled since the shutdown in Alabama. Many of these facilities are starting to find themselves that they have to dip into their block grant funding now more than they ever have before. But that's particularly because there's a lot of people, or you're working with a lot of people and patients who have lost or do not have insurance. So my question is, what steps are being taken, or what steps that we can assist with to protect the sustainability of those programs as we move through this and beyond? I know COVID-19 is our top priority, but I want to make sure that people that might be, suffering from the isolation or the mental health trauma that might be inflicted from the isolation, might be resorting to drugs or alcohol. I want to make sure that they have a place where they can seek the treatment that they might need. And that's it.
Wow. You know what? That is a really great question. And let me get back with my team, because that's a question that needs some very well thought out answers. So let me make sure that I understand. You want to know what steps the state needs to take to sustain programs, because, well, you are right. And in fact, I have 2 articles, one from the Washington Post and one from the Los Angeles Times, that are talking about the long-term mental and emotional impact of this disease. And we just heard Dr. Saag say he had fuzzy thinking.
Right.
So people are going to present in a whole new way to us with symptoms that we may have never seen before. And it is going to be disturbing to them, I'm sure, as well as to those who are trying to serve them. And so let me get back with you on that.
Yeah, yeah, no problem. I understand
Thank
that
you.
that was probably a big,
Yeah.
big question there, and I'm happy to help in any way I can with that as too.
Thank you, Representative Rafferty. I appreciate that so much.
Are there any other questions? Dr. Beshear, we really do thank you for participating, and we see that we have so many more questions than we do answers, and we look forward to working with you to do what we can from our caucus perspective to help you achieve goals that will help our constituents. So we appreciate it this morning. Thank you. Thank you. We will now turn it over to Representative Sam Jones and Representative Neil Rafferty for our next session dealing with veterans. Representative Jones and Representative Rafferty.
Good morning.
Good morning.
Good morning. Our session is serving our veterans during the crisis. Representative Neil Rafferty will be on this panel as one of the moderators, as I will, and we are happy to have Rear Admiral Davis, who is the Commissioner of Military Affairs, or Veterans Affairs, and I serve on the Military Affairs Committee, as well as a number of our other members of the Democratic Caucus. So we've heard Admiral Davis, and we've heard him talk about veteran affairs, but this is a very important time for all of us. We really like to know how our veterans are faring, and what I'll do at this point is turn it over to Representative Rafferty.
Well, sure. So I think we have Admiral Kent Davis on. We have him on here? Can we hear him?
I'm here, Representative.
There you go. So we'll just start off with kind of hearing your thoughts about what's going on in the veterans community here, particularly in our state-funded veterans homes, and kind of hear what some of your concerns or some problems that you're seeing, what concerns you might be seeing, and what solutions that we could work together and collaborate on to appropriately address.
Thanks so much, Representative Rafferty and Representative Jones. Really happy to be here and share some thoughts with you. I did want to give a couple of shout outs before I start. First of all, thanks to Commissioner Beshear. She has been a great partner. As you can imagine, there are mental health issues that are specific to the veterans community. She has been a great partner on that, along with Representative Rafferty on things like PTSD and veteran suicide, which is a national tragedy that we're facing in this country. I also wanted to say hello to my old friend, Dr. Barbara Boyd. I saw her on there. We used to be neighbors up in Calhoun County. So Dr. Boyd, I haven't seen you in a while. It's great to see your face. So the basic question, how has COVID-19 affected the veterans community? Well, I'm not going to sugarcoat it. Massively. It has been a huge impact on us. I will talk about the status of all of our facilities. I'll try to touch on the status of federal services with the U.S. Department of Veterans Affairs because we interface with them quite a bit. Just to put things into perspective, in the Alabama Department of Veterans Affairs, we have about 1,200 employees, and they work in 60 or more facilities around the state of Alabama, often in partnership with the federal VA and often in partnership with local counties. And as you can imagine, as we're dealing with guidelines from the federal government, from the state, especially the governor's guidelines on COVID-19, and those local guidelines, it's been an interesting mixture of the precautionary measures we've had to take and how it has affected those 60 facilities that we have around the state of Alabama. Now, our proudest statistic is we serve about 400,000 veterans in Alabama. That's a pretty astounding number. That's one of the highest per capita figures amongst the United States for veterans, and we're proud of that in Alabama. To put that in further perspective, about 1 in 10 adults in Alabama has served in the military and is now a military veteran, so we're proud to serve them. It has been an impact the last couple of months in providing service. We work very closely in unity with the federal VA on providing services to those veterans. And let me just go through some of our facilities and how it's impacted and how we're getting back on track now to provide services to those great veterans across the state. So first of all, one of the first points of contact that a veteran in Alabama has in the veteran system is through what we call our veteran service offices that are spread around the state of Alabama. These are county-based offices. We have currently 51 of those offices. Our plans were by the end of 2020 to bring that number up to 60 total veteran service offices. We used to have offices in all 67 counties in Alabama. With the budget situation about 10 years ago, difficult decisions were made to close those offices, 17 of those offices. I came into this job 15 months ago, I felt like when I looked at the map, some of the most affected communities by those closures were the poorer rural communities in Alabama. So we made a promise that we would start reopening offices around the state of Alabama. We hope the COVID-19 situation and the budget situation will not upset that plan. So we hope to get to 60 offices by the end of 2020. We had just opened a new office in Chambers County right before the COVID-19 situation hit. Because of the social distancing measures and the original stay-at-home orders from the governor's office, and because of the closures of many of the county offices that those facilities were located in, those offices were closed for several weeks. On May 4th, thank goodness, we reopened those offices around the state. So 51 offices reopened in some capacity. Now, again, it's a mixture because we're often bound by those local restrictions. A lot of our facilities are in county courthouses, county admin buildings, some of which have not reopened to the public yet. But all 51 of those offices now are available to provide services to veterans. Even that's a little bit of a misnomer because even during the shutdown, we were providing telephone services to veterans, and I'm not aware of any veteran that fell through the cracks that was not able to get services that they needed during the shutdown of those facilities. And we maintained a lot of telephonic contacts with veterans. But right now, we either are able to do face-to-face appointments, keeping social distancing measures in place, or telephonic visits with veterans. Sometimes we use Zoom conferences with veterans. We can take applications for federal benefits and make sure they get to the right place. So I'm very happy. As of May 4th, those 51 officers are back in operation. We have posted the status of every single one of those 51 offices on our website at va.alabama.gov. So any member of the public can go there and find out the exact status of any of those 51 offices. And that status includes phone numbers and emails where they can initially reach out to those offices, and we will be glad to provide services to our great veterans out there. The second facilities that I want to talk about is both our state cemetery. We have a state veteran cemetery down at Spanish Fort, and there's a series of national cemeteries across the country. Right now, here's where all of those cemeteries stand. We are continuing to do casket burials, and we have throughout this crisis. We've kept a skeleton crew at our state cemetery to continue casket burials. We thought that was important for several reasons, because just to be frank, when there is a death of a veteran or an eligible spouse or family member, the options for the interment of that veteran or spouse are limited. A lot of private cemeteries right now have cut back and restricted severely burials. There are no memorial ceremonies going. We thought it was important to continue the burials, if nothing else, to save the cost of morgue storage for families. So throughout this crisis, we've continued the casket burials. We continue to do so now. Because of the social distancing measures, we're not able to do large memorial ceremonies at the gravesite. And the Department of Defense and other organizations have not resumed military honor guards yet, so we're not able to do those appropriate ceremonies in conjunction with the burials at present. What we're telling all of the families, and everybody seems to be very cooperative and understanding with this, is we've said, let's do this. Why don't we go ahead and conduct the casket burial now? We will schedule a full memorial ceremony with full military honors at a later date when those services can resume. Because again, we're relying on the federal government, local institutions for a lot of those services. And families have been very receptive to that. And hopefully the restrictions will be lifted and we'll get back into full business at the veteran cemeteries very close in the future. We are planning, everybody's being inventive these days. Normally we would have a huge Memorial Day ceremony at our veteran cemetery. The current restrictions still do not allow that. So we're going to plan a very small ceremony with appropriate military honors that will air on Facebook. So anybody can tune into that as a virtual ceremony. We think that's appropriate to honor those who are interred at our state veteran cemetery down in Spanish Fort. At headquarters here in Montgomery, we have a very small headquarters in downtown Montgomery. We are open. We encourage the public, if they need anything, to contact us here at headquarters. The number here at headquarters is area code 334-242-5077. And I tell everybody, if all else fails, if you need veteran services and you can't contact for whatever reason one of your local offices or the federal VA, call us here. We'll make sure we get you to the right point of contact to take care of your veteran services needs. The last type of facility that we manage that I want to talk about is frankly the most difficult challenge that we've had. And I'm not going to sugarcoat this. This has been a very, very difficult situation, and that deals with our state veterans homes. We have 4 state veterans homes in Alabama, one in Huntsville, one in Pell City, one in Alexander City, and one in Bay Minette. We have managed, thankfully, to keep the virus, the COVID-19 virus, out of 3 of our 4 state veterans homes. Unfortunately, it has gotten into the veterans home in Alexander City, and you've probably seen this in the news. So what I thought I would do is I want to walk through a timeline of events and talk about some of the difficulties we have faced in that home. It's called the Bill Nichols State Veterans Home in Alexander City. So as far back as March 10th, before Alabama even had its first positive COVID-19 test case, we started screening employees in all of our state veterans homes because we feared that it was going to get here and we were going to have to deal with especially asymptomatic carriers within the state. So on March 10th, we started screening all employees every time they entered any one of our facilities. On March 12th, we ceased public visitation in our state veterans homes. The only people that were allowed into our state veterans homes from that point on March 12th were the staff members, obviously, because they have to care for the residents. Occasional external medical personnel that had to come into the facility because we do bring in external medical experts from time to time for the care of those residents. And a very narrow category of immediate family members for humanitarian reasons when a resident was facing an end-of-life situation. As a humanitarian measure, we thought it appropriate for immediate family members to be able to come in and visit their loved one who was dying. Even in those cases, with those limited entries into the facility, every single person from March 12th on has been screened at a single entry point in every facility to try to keep the virus out of all of our homes. Unfortunately, the Bill Nichols home, as has been reported in the news media, is kind of in the center of a hotspot in Alabama for COVID-19. If you look at Tallapoosa County, Chambers County, Lee County, that is one of the hotspots. So our fear was always, as some of the medical experts have talked about, that asymptomatic carriers would somehow get that virus into especially the Bill Nichols home in Alexander City, considering that was a hotspot in the state. With the screening procedures we had in place for staff, in late March, we turned away one employee who we thought was at risk, did not allow them into the facility. That employee eventually on March 30th tested positive for the virus, and we thought we may have a problem. We may have had an exposure in the facility. And our fears did play out. On April 3rd, we had our first resident that we tested who was exhibiting symptoms. And then on April 8th, we had our first confirmed case of a resident within the facility. Now, I'm not a clinician, I'm not a doctor, but we all know the high-risk populations for COVID-19. And unfortunately, long-term care facilities, nursing homes are kind of the worst case scenario for high risk for COVID-19. You have elderly residents. Secondly, they all have chronic health issues, most of which suppress their immune system. And then you add to that a high density indoor population. That is probably the worst scenario you can imagine for COVID-19 infections. And that's what is happening across this country. You've seen the figures. Now the estimates are that about 1/3 of the deaths in the US have occurred in long-term care facilities in the United States. That is a very tough lesson learned in this tragedy that we have seen over the past couple of months. Well, April 8th, we had our first resident test positive for the virus. That resident was immediately isolated using CDC procedures within the facility. And by the way, any staff member that tested positive from that March 30th test was not allowed into the facility at all, which creates a ripple effect because as you exclude staff members, of course, you have to augment those staff members from elsewhere. We've been able to do that. So this disease has a ripple effect that sometimes you don't initially think about. And we've seen that drastically over the last couple of months. So April 13th, that week, we started having more positive test results come back for residents and staff, and that really set off the alarm bells with us. So we sought outside assistance from several organizations. First of all, we knew that we had put in pretty drastic precautionary measures that I've already talked about, but I wanted to ensure that we hadn't missed anything. So I reached out to two organizations that have statutory inspection authority over us. One is the federal VA. The other is the Alabama Department of Public Health, and I talked to the senior officials of those organizations, and I asked if they could come in and do an independent assessment of our facilities, especially the Bill Nichols facility. They agreed to do so, and within a few days, they sent separate teams. The federal VA sent an infectious disease team into the Bill Nichols home, and then separately, the Alabama Department of Public Health sent an infectious disease review into the Bill Nichols home as well. And they spent a lot of time looking at our procedures, the timeline, just to make sure that we haven't missed anything in our precautionary measures to try to stop the spread of this virus as much as we could given the circumstances. Those teams issued their reports. They were in agreement independently that we'd done pretty much everything we could. They made some minor recommendations. They did note we were okay on the use of on the supplies of personal protective equipment, the cooperation amongst our staff, the communication we were doing with family members, because we've tried to be transparent with family members, with residents, and the news media. We've sent out press releases at every milestone telling them, here's what has happened in the Bill Nichols home. Just as a state agency, we thought we needed to operate in the sunshine. We also sought assistance from the Alabama National Guard. Probably doesn't surprise you. We knew as veterans ourselves here that there are specialties within the National Guard that can help with this. They immediately responded, and the week of April 19th, actually April 18th, they sent a team of specialists into Bill Nichols to do cleaning, sanitizing, and decontamination very thoroughly in the Bill Nichols home, and they have subsequently visited the other 3 veterans' homes, and now they're visiting the private nursing homes as well in the state, just to take that added external step. We've also contracted with private companies, I won't name the names, but private sanitizing companies that have come in and done periodic similar services, just in an effort to kill the virus to the maximum extent possible within especially the Bill Nichols home. As some of the other specialists have talked about, one of our big concerns has been the availability of testing, especially early on, because as I mentioned, our early concern does not take a medical doctor to come to this conclusion. Our biggest concern was what we call the asymptomatic carrier, someone who has the virus that can spread it to other people, and we have no idea because they're not exhibiting symptoms. Well, the protocols for testing until very recently, until the last few days, has been in Alabama that you could not test someone unless they were symptomatic for the disease. which is a problem in a place like a nursing home because it's too late at that point, frankly. And we have been talking about that for well over a month. Now, there have been some interventions. Thankfully, the state health officer, Dr. Harris, agreed on April 17th to do complete testing of the residents at the Bill Nichols home in Alexander City. And we completed that the very next day on April 18th, 100% testing of the residents in that facility. As the test came back, we found out, indeed, we had a lot of asymptomatic positive test results come back. This kind of surprised me, I will be honest. Well over a third of the residents that have tested positive for the virus in the Bill Nichols home continue to be asymptomatic, even though they're in the high-risk population of elderly with chronic health conditions. Now, it's a double-edged sword because as you do the universal testing, you find out that you have more positives and you realize we have a much bigger issue on our hands because you have those asymptomatic carriers that you had no idea were a risk, and you have to isolate them as well. So we have done massive isolation procedures as those test results have come back positive within that facility. So obviously it's been a very, very difficult challenge dealing with this once it gets into a facility like that. And you've seen the news reports. This has occurred across the country in both state veterans homes and in private nursing homes across Alabama and across the country. This is a national issue that a lot of communities are dealing with. Getting back to the communication, because of the isolation procedures and tying in a little bit with what Commissioner Beshear said, we realize how difficult that is when we've restricted visitors and we don't even let family members come in and visit residents. We've had to be a little inventive with things like Facebook and FaceTime so family members can at least stay in touch visually and verbally with the residents in this home. So we've instituted policies where people can do that. And sometimes we've done window visits with families and residents so they could at least see and talk to their loved ones inside the facility. So that's another ripple effect that you don't originally think about, but you do have to think about the mental health impacts of the whole COVID-19 physical impacts and how the social isolation impacts people. Bringing you up completely to speed and taking the communication further on, I had done several media interviews and I had done a town hall public Facebook Live session through AARP. On May 1st, I said, I think we need to do another one. I did a Facebook Live town hall meeting on May 1st that reached about 15,000 people. And we talked about all of these measures. We talked very explicitly about the difficulties we had faced, especially with the Bill Nichols home, some of the things that may be happening and our plans for getting back to some semblance of normality in some of our facilities. Last week, I did send a written request. I thought it was important to formalize this, even though we had been asking for universal testing of staff and residents in all of our state veterans homes. I put it in writing and I said, okay, I think everybody has reached a consensus that we need to bump up the priority for nursing homes, long-term care facilities, but especially the state veterans homes. They need to be bumped up in priority for testing. Folks in Alabama Department of Public Health and the State Emergency Management Agency are working on that request right now. And I hope soon we get a thumbs up and the capability of doing universal testing of staff and residents in all 4 of our state veterans homes. I do think that's important. I also think it's important to do periodic retesting. Other states have already done that. North Carolina is an example, and I've talked with them extensively because, as you know, the insidious nature of this disease, someone can be negative today and positive tomorrow for it. That's how quickly things have changed. So we've made that formal written request. We've gotten a positive reception to that. And we think in the next few days, hopefully, perhaps with your support, we'll see that come to fruition and be able to implement that full testing of staff and residents in all of our homes. So here's the saddest part. Right now we have 41 We have 41 residents in our Bill Nichols home that are still considered active positive for the disease. And we have had 23 confirmed deaths from COVID-19 in the Bill Nichols facility. That is one of the hardest facts I've had to talk about that I can remember. We exist to take care of veterans. And to face a tragedy like this, first of all, is a massive crisis for the residents, the families of those loved ones, our staff members that work in those facilities. If you want to talk about a mental toll on folks, we deal with that daily. I say that not to be melodramatic, perhaps a little emotional, as we should be sometimes. But just to let you know, this has had a massive impact on all of us. I do want to reassure, we are doing everything that we can and will continue to do everything we can to try to combat. This fight is not over. It's going to continue for a while, and it's going to take the cooperation and teamwork of everybody in this fight. I'm willing to give it my all, and we are here for the long haul to fight this insidious disease and do whatever we can. I hope to have some good news with testing. That has been an issue. I think that's a key in all of this. And I would be glad to update you on any of these status checks that I've given you, even the more difficult situations. You are welcome to reach out at any time if you need my assistance or you or your constituents have questions or concerns. And with that, I will leave it and open it up for any questions that you might have for me right now.
Well, I think we do have one question from Representative Boyd. So the host can unmute Dr. Boyd and we let her ask that question. She has her hand raised. Dr. Boyd?
Muted. Am I unmuted?
You are unmuted. We can hear you now, Dr. Boyd.
Thank you so much. Admiral Davis, I want to first thank you for your service to Calhoun County, even to the state and to the nation. My question had to do with what you've already touched on. I was going to ask you which was your immediate needs that we could do as policymakers. But as I took notes, you said universal and retesting. And you've only been there a short time dealing with the 6 offices and the Bill Nichols home in particular. Of those, if you were to prioritize those, which would you think would be your most urgent need?
Thanks, Dr. Boyd, my old friend. We go back many years up in Calhoun County. I was the city manager up in Anniston, Alabama. I think the world of her. So to retouch on what I was talking about, the key in all of this, as Dr. Saag, Dr. McIntyre talked about, is testing, 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 because it gives you a picture of who is positive, especially identifying those asymptomatic carriers. It is probably time already to do retesting in the Bill Nichols facility. If I could wave a magic wand and do 100% testing of staff and residents in all 4 of our state veterans homes today, that would be my #1 priority, period, because it would at least give us a snapshot of how bad is the problem. Do we have a problem in one of our other state veterans homes? Even though we've kept it out of 3 of the 4 homes, I literally have nightmares that it's going to get in one of those other homes. And the biggest danger is that asymptomatic carrier who gets into the facility and spreads the disease that you have no idea is doing that. So testing is the #1 priority. It's got to be, because it gives you a baseline of how your problem is, and it allows you to implement things like isolation of those who may infect others.
Thank you so much.
Yes, ma'am.
Are there any other members who have any questions? for Commissioner Davis?
For
All right. Well, Commissioner Davis, I'd like to thank you for coming on and sharing what the state's doing to support those who bore the battle. Appreciate everything that you're doing and appreciate your time. Representative Jones, I'll leave it to you for any closing remarks you may have.
Mr. Davis, let me thank you for your time and all of the information you shared with us. That is a very critical area as it relates to long-term care facilities. And for you to have 3 other facilities that you have managed not to have that much of a problem in, you've done a great job working with those facilities. And I'm sure you have at the Nichols Center too. It just depends on what happens daily in situations like this. And one question I had was for the future, this, and it looks like it's going to be with us for a while. Do you have any questions for us as to how we could help you try to limit the spread of COVID?
Great questions, Representative Jones. Education and communication is vital in this. You know, some people may think this is a little silly, but little measures like this, I don't leave my office without a face mask. You know, it's easy in a place like our state veterans homes to institute universal personal protective equipment, but I do find around the state, there's still a little bit of lack of knowledge about how this virus is spread, the true danger of it, the high-risk populations. And a lot of people, I think, don't understand when you do things like this, you're protecting yourself a little bit, but you're mainly protecting your fellow citizens, because we know this is an airborne disease. And if you can do something as simple as this, and if all of us can help spread information about the importance of protective measures like this and social distancing and avoiding those large high-risk situations, I think will help. I am convinced we had an asymptomatic carrier that brought it into our facility, perhaps someone who was not taking the precautions that they should have. So that, and just know that we're here to support you as well and your constituents, because your constituents are our customers, and let them know we're here to serve them without charge, without any ulterior motive, 24 hours a day.
Again, thank you. Thank you so much for the passion you've shown for what you do for the veterans in this state. And thank you for giving us your time and talent this morning.
Thanks, sir.
It's our panel. If there are no other questions, we have completed our session, our part of the session. So we'll turn it back over to Representative Drummond.
For moderating this session, and especially thank you to Admiral Davis. We thank you for giving up your time, and you know, I was sitting here listening to you and I can see the passion that you have for this job. So I know that this is a great addition. So thank you. We will now turn it back over to our leader Daniels, and we want to
Hello.
Hello. Can you hear me?
Okay, can you hear me now?
I can.
Yeah, we can hear you now. We can hear you now.
Again, I will repeat it. I want to thank both Representative Jones and Representative Rafferty for moderating this session, and especially to Admiral Davis for all that you are doing for our veterans. We can see your passion, and we know that that's a good fit for Alabama. So thank you for what you're doing. And we're here not only to assist you, but anything that you may need from the legislature, please let our caucus know. We'll do all we can to help you. So we appreciate you as well as Dr. Beshear. We want to thank you for all the work that you're doing, and to all of our Facebook followers, who are on this session. We thank you for taking time, and now we will turn it over to Leader Daniels. Thank you.
Thank you, Representative Drummond. Thank you for all our moderators today and all of our participants. Thank you for our panelists as well. It was a great day, great session, and great information. And also for the general public. And say to you guys that, we appreciate what you do and we're here for you, just to reiterate what Representative Drummond mentioned. And we'll continue to offer these throughout during the duration of this time period for the next couple months, just providing information and getting a better understanding of where we are, assessing where we are and what we should be doing as lawmakers to or thank you for us. With that, I have no further statements, and I'll turn it back over to the leaders for questions, Representative Drummond, England, and Hall to close us out.
We certainly thank all of our co-chairs, and I will turn it back over to our original co-chair, which is Representative Hall. And again, we thank you for not only tuning in, but for participating, and to all of our members for participating in these 2 weeks of session. We've had a whole lot of questions, and we're hoping that we'll get a lot of answers so that we can help move Alabama forward. Representative Hall.
Thank you, Representative Drummond. I am appreciative of the time and the information that we've been able to gain today. And a thank you to each one of you. And I look forward to our next session as we can continue to ask questions and seek answers. Representative England.
Yeah, I think that about wraps it up. So one thing that's always in order is a motion to adjourn.
So move.
All right.
Second.
That sounds good. I think we have another session scheduled on Thursday, so on the census. So we will hopefully see you then. All right, thank you.
All right, thank you.
Bye.